Post-operative pain is one of the leading issues faced by health professionals in healthcare, as unresolved pain can lead to numerous health issues, including but not restricted to delayed healing, higher complication rates, and increased suffering of the patient. Proper pain management can minimize morbidity and prevent complications which delay healing and patient discharge. Despite this, there has been little improvement in post-operative pain management, and in some cases, low priority of pain management amongst health professionals. In a study conducted on patients post-cardiac surgery in Australia, 86.3% of patients reported tiring or exhausting moderate to severe pain. Moreover, 45% of patients reported having to wait for pain relief at least once during their critical care admission, and a prevalence was found of patients over 65 years of age who were refused pain relief or received less pain relief than those under the age of 65, despite reporting more pain experience. Furthermore, the study found that in surgeries with greater associated post-operative pain, there was no difference or increase in the amount of pain relief given to patients who underwent these procedures. These factors of high-level pain, inadequate pain relief, and delays in administration of pain relief impacted on the care plan cardiac patients followed, of attending physiotherapy as of the following day post-surgery. This caused them to be unable or delayed in reaching the expected goals of their care, and thus a delay in recovery and discharge occurred. The issue of poor pain management post-operatively is also seen across the world. In a Swedish study, an overall below acceptable level of post-operative pain management was evident. Also reported in the study was that most patients did not believe the healthcare workers knew the amount of pain they experienced, and that patients were not always assessed daily on a numerical 0 to 10 pain score. In order to improve post-operative pain management, 3 recommendations have been identified across studies. The first recommendation found is the quick recognition and treatment of pain through assessing with a valid tool. The current research shows that across a range of procedures, only 70% of patients reported having at least one pain score documented post-operatively with a scale. However, of these patients, only 60% reported having been assessed at rest and at movement. Furthermore, in a specialized setting, 46% of pediatric nurses reported being strongly familiar with pain scales used for children. However, 31% of them reported it was difficult to use the pain scales during their shift. Here we can see that across the generalized healthcare setting, pain is being assessed using the appropriate tools, however not in the valid assessment method or easily. This may be due to factors such as inadequate staffing and busy shifts, or a lack of confidence for the nurse to assess properly. Solutions to this issue may include reviews of working conditions and staffing levels, as well as nurse education on the use of pain scales and appropriate assessment methods. Specifically in the pediatric setting, nurses commented that the scales were often inappropriate for some patients and certain age groups, and that 86% of nurses use their own intuition and impressions to assess pain levels. To rectify this, pediatric subgroups such as infants, toddlers, and teenagers may require their own assessment tools or methods to ensure the pain is assessed properly. Another recommendation is the education of nurses on pain management and why it is important. As mentioned, despite the research and suggestions that uncontrolled pain has great complications and that good management has benefit to patients, there is still evidence that pain management was a low priority to nurses. In an Iranian study, nurses stated that hospital policy and organization placed pain management of lower importance than other activities, which in turn trivialized the experiences of pain the patients went through. There was also an emphasis that the pain management was the role of the doctor and that the patient should expect to feel pain as a normal part of the post-operative experience. It is easy to see how these attitudes arose, as nurses complained of being dependent on prescriptions and, when lacking, often found the surgeon or doctors difficult to contact. To solve these issues, there is evidence of a need for a better multidisciplinary approach which would actively involve the role of nurses in pain management instead of continuing the doctor-only responsibility approach. Another example is the inclusion of physiotherapists to ensure that patients have adequate pain relief before attending therapy sessions, to promote the timely meeting of patient care goals. There should also be a greater emphasis on pain management from facilities and their policies, with promotion of good pain management and its benefits from those in authority positions. Pre-written prescriptions may also lift the burden from the doctors and allow nurses to be more proactive in managing pain. Finally, in-services such as this one can help nurses to better understand the negative impact of unresolved pain on the patient and the hospital and society as a whole, to change their beliefs or misconceptions about the importance of pain management. In support of this, there is evidence to suggest that nurses who attend pain education were able to treat patients' pain relief more effectively. A final but key recommendation is that the patient should be educated and included in the creation of their own individual pain management plan. Patient-centered care is the basis of healthcare and should be implemented in all aspects of this care, including their pain management. 94% of patients in a recent United States study reported that they wished to be included in the decision-making process of their care, and of this, 88% stated feeling very satisfied with their care. In order to achieve this, pain management should begin in the pre-operative period to adequately explain to the patient what the expected levels of pain are and what plans there was to management. It was also found that there were factors which caused more pain to be experienced post-operatively, which should be assessed in the pre-operative period. These included more pain experiences by those with existing comorbidities and amongst patients with specific surgeries associated with high levels of pain post-operatively. Currently, research suggests that only 55% of patients receive pain management education preoperatively, and that even though they do receive this, many still state their concerns are not adequately addressed in this period. Furthermore, patients felt they could not report pain to their nurses as they felt they were disrupting the nurses' busy shift schedules. Here we can see a deep lack of effective communication with the patient in regards to pain management, as the patient feels uncomfortable to report the pain experiences. A lack of staffing and large workloads continuously appears to be a barrier towards pain management and is evident in the context of this recommendation, and the effect is not just seen on the nurse but on the patient as well, who perceives the nurse to be too busy to bother with their pain. This discourages the patient from engaging in the care presented to them, and is evidence to suggest the patient may perceive their pain as not important or as something they simply should just bear. Another barrier may be the emphasis in the pre-operative period on the information needed by the anaesthetist and surgeon completing the procedure itself, rather than the worries of the patient or post-operative information the patient should require. Solutions to these problems include the proper building and use of the therapeutic relationship. Creating a proper therapeutic relationship will allow the patient to seek out the assistance of the nurse without feeling burdensome or distressed, and it will also allow the nurse to properly identify the patient's signs of pain or discomfort which may not be immediately present. Furthermore, the role of all members of the multidisciplinary team to address the concerns of the patient preoperatively should be emphasized in individual hospital policies and preoperative checklists. This is also the first step towards a therapeutic relationship and is the foundation for the good pain management postoperatively. This is also a time where other factors such as comorbidities should be assessed to plan the appropriate pain management for each individual patient, as blanket plans and policies may not include these factors. Appropriate pain medications should also be assessed and planned for in this period to allow for prescriptions to be prepared and potential medication interactions to be assessed and managed before the patient is requiring pain relief postoperatively. Language barriers may also exist, but can be solved simply with an interpretation service. In conclusion, we can see why it is necessary to manage postoperative pain and what current practice research gaps are evident in our management of this issue. With the solutions discussed placed into practice, we will be able to reduce complication rates, prevent chronic pain issues, allow patients to complete their care goals, and improve patient hospital experiences. In order to achieve this, one serious barrier to be overcome is the staffing and nurse workload issue, as it appears as a barrier towards all the recommendations discussed.